Thank you, respected chairperson. I'm going to, in the next 10 minutes, speak about mitral valve clip and other percutaneous mitral valve interventions for chronic mitral regurgitation, the concept and the possibilities in future, and where we are today. Now, if you see the mitral valve, it's a valve because it's an audience of Delhi CSI members also. It's a valve which is a bileaflet valve between the left atrium and the left ventricle. It has an apparatus, it has an annulus, leaflets, chordae tendineae, papillary muscle, and the left ventricular myocardium. So this is the mitral valve apparatus, and any problem with any of these components can lead to mitral regurgitation. Now, MR occurs as a result of malcoaptation of the leaflets, which could be primarily because of the leaflet disorder, which could be flail leaflets, a prolapsed leaflet, or because of papillary muscle dysfunction. Or it could be a functional MR because of annular dilatation or left ventricular enlargement. Now, if you see the data from the surgical options for mitral regurgitation, it is clearly evident that more patients require mitral valve reconstruction rather than mitral valve replacement, and also the mortality is much lower in mitral valve replacement. So based on the surgical principles, we actually, the interventional cardiologists have started approaching mitral valve percutaneously, and the possibilities are the leaflet repair, coronary sinus annuloplasty, direct annuloplasty, chamber and annular remodeling, and caudal replacement. Of this, the leaflet repair is the most popular and widely accepted technique and a promising technique. Coronary sinus annuloplasty is another one which is being considered as a good option. And also the direct annuloplasty, direct mitral valve replacement, which are in pipeline. And also the chamber remodeling, which is based on reducing the LV volume. So I'm going to speak about it. The field of transcatheter mitral valve replacement is fast evolving. These emerging technologies differ in the site of action, and there is no one solution to all patients. So it has to be a good selection of the patient and a good indication. And mitral valve, as of now, the mitral valve clip is a leader in the field, but several other technologies are in pipeline, and developments are showing promises. Now, of the various percutaneous approaches which are there, they are based, all of them are based on long-term concept of surgical repairs. Now, the most important thing is the mitral clip. And this is based on Dr. Alfieri's principle of treating chronic mitral regurgitation. And what Dr. Alfieri did, he evolved a stitch, and the stitch was put in the central part connecting the anterior mitral leaflet and the posterior mitral leaflet, thereby reducing the mitral valve orifice and decreasing the mitral regurgitation volume. The other concepts are based on the mitral valve replacement, and because of the success of TAVI, which we heard in the previous talk, there have been approaches, transeptal mitral valve replacement, which is the CardioQ device, and transapical mitral valve stent implantation, which are both stents which have the valve embedded in the stent. These are not in human use, they are in animal trials, animal experimental stages, but they show promise for future. The thing which is currently being used is mitral valve clip and annuloplasty, because the coronary sinus runs above the mitral valve annulus, and if we can reduce the circumference of the mitral valve annulus by clinching the coronary sinus percutaneously, we can probably decrease the annulus size and decrease the mitral regurgitation. So we have two sort of devices here. One is indirect annuloplasty, which is a clinching device, the cardiodimensions Carillon device, and we have a direct Equilynch device which is being studied. And then we have a direct angioplasty, annuloplasty device which goes through transventricular approach. And also we can remodel or we can decrease the LV volume based on the MyoCore surgical coapsis system, that we put a stitch between the septum and the lateral wall of the LV, decreasing the LV size and volume and mitral regurgitations. The device in use clinically are the mitral valve clip, which I'm going to just go through. I've given you the concept. There are a few sort of exclusions. If you have a flail gap more than 10 millimeter, this device is not used. If you have a flail width more than 15 millimeter, an LV end diastolic dimension of more than 55 millimeter, we don't use this device, and this is at present only used for functional mitral regurgitation. This is how it works. This is a small video. We go femoral, we go to the right atrium, then do a septal puncture, which is done a little higher than what we do for the balloon mitral valvotomy. And then, once we have done a septal puncture, we put in a sheath, and then through the sheath, we have the mitral clip. It is a deflectable device. We orient it to the axis of perpendicular to the axis of the mitral valve, and this is all done under TE guidance. And once we are sure of our the direction, we advance the clip down into the left ventricular cavity. And we have to orient it in also along the commissures. So we advance the clip into the left ventricular cavity, then pull back, and it would clinch the anterior and posterior mitral leaflet. The beauty is that we can assess on table the reduction in mitral valve regurgitation, and if we are not sure, we can retry and reposition it at a proper place. So this is a very sort of a user-friendly device, but we need to select our patients properly. We need to be good in septal puncture and good in transesophageal echocardiography. So once the clip is in, we detach the cable, and the patient can be sort of discharged. It is not done under general anesthesia. It's done under local anesthesia. We close. We do it entirely percutaneously. We close the radial artery access by a TR band, and the femoral access by per-close or pre-close. Now, there has been a worldwide data on mitral valve clip therapy. I'm not going to go to the details, but because of the paucity of time, the trials are Everest 1, Everest 2, Everest 2 high-risk registry, the Realism registry, and the European experience. And more than 3,000 mitral clips have been implanted worldwide, and the results have been very encouraging in selected patients. The acute success rate has been more than 90%. The 30-day mortality has been less than 5%. Stroke rate has been less than 5%. And most of the patients showed clinical improvement and also improvement in the LV remodeling. Now, this is the data from Everest 2 high-risk registry showing the evidence of efficacy of this procedure, also a decrease in the rehospitalization rates, and also the safety of the procedure. So I'm just going to skip this. This was published in the New England Journal of Medicine. I'm going to skip the studies because of paucity of time. Then the other device which I want to tell you about is the COAPT. The other study is the COAPT study, which is based on the mitral clip therapy in surgically high-risk patients. And this study also duplicated the results of the Everest 2 trial. So in conclusion, mitral clips treatment is safe, effective treatment option in selected patients of chronic mitral regurgitation. It demonstrates meaningful clinical benefits at 1 year, evidence of durability up to 2 years, and surgery still remains the treatment of choice. The other devices I told you were a Carilion device for mitral coronary sinus clinching, but these devices have undergone trials, which is a Titan trial, but these devices are still not in clinical use. This is a slide, the last slide maybe is just showing you that percutaneous therapy for mitral valve is feasible, and this is one of the patients who had a percutaneous mitral clipping as well as an aortic valve replacement. Thank you very much.
What is the main criteria for selection of these mitral valve patients? What are the main criteria for selection?
The main criteria is that these patients have to have first non-rheumatic mitral regurgitation. That's one. The annulus should be dilated, and mostly it is done for chronic mitral regurgitation because of flail leaflet or because of prolapse of the leaflet. So mitral valve prolapse is one indication, and heart failure with annular dilatation is the second indication.
It should be non-rheumatic.
It has to be non-rheumatic.
Thank you.
If it is more than 10 millimeter, then this is not recommended. That is what.
Then this device is not suitable because the device can only open up to some. While you are deploying it, it can only open to a certain diameter. You have to pull it back and then clench it. If the gap is more, this device won't fit in, won't catch the anterior and posterior mitral leaflet.
Okay.
Dr. Khanna, here, yeah, as always, very eloquent and very nice presentation. Just a collateral question. You know, we have MR, and then collateral question it is. TR is rampant, right? And any work going on parallel by the interventionalists like you, what do you think is the future of tricuspid valve?
Annulus. There's nothing like this which runs on along the tricuspid, above the tricuspid valve. So for that, we do not have a percutaneous treatment as of now, but I'm sure it would develop in future time.
One is frame, another one is the valve area. So that has been done by, in humans, already published in JACC by internal jugular route.
I know that's one anecdotal cases, but the problem with the tricuspid regurgitation and tricuspid intervention is that the gradient is very low. These valves tend to thrombose very fast, and there has been no animal data also to. Pardon me?
Retinol frame, stent frame is retinol.
I didn't hear you.
Why prosthetic?
I didn't hear you properly.
Sir, thanks for the good presentation. Sir, this is safe for geriatric age group.
Yes, this is reserved as of now only for geriatric age group or for very sick patients where surgery is very high risk and sort of it limits us for a surgical intervention. Only in those patients it is indicated, and that too only for heart failure patients and severe mitral valve prolapse patients. It's not a it's a device for primary use. It is still indicated for desperate use.
Thank you.
Do you recommend this technique for below a particular ejection fraction? I mean, some patients who are having ejection fraction of say less than 20%, but otherwise general health is good, then would you send them for L3 repair surgically, or would you recommend mitral clip for patients with ejection fraction less than 20% with good health general condition?
Actually, this depends on, it has to be as per the trials, the high risk Everest 2 high risk registry. The patient has to be classified as high risk for surgical procedure and refused by surgeon. And then it's a combined decision between surgeon and the cardiologist to go for this therapy. And there are a lot of patients included in this trial which had ejection fraction less than say 20-25%, but most of these patients were in heart failure class 3 and 4. If you have a 20% EF with a good compensated heart failure or just an NYHA 1 or 2 class, I think surgery would still be a better option.
Anybody in India doing this mitral clip?
No, it's not available in India because the drug controller doesn't allow us to use it.
Bioprosthetic valve, degenerative bioprosthetic valve in the mitral position. They have used this Kribier's valve, that is the same Homo sapiens valve in that position, in the frame of degenerative bioprosthetic valve. So valve in mitral position.
That's possible, but two other valves are being developed dedicated for transeptal route as well as apical route. So there are dedicated valves being developed for mitral valve percutaneous replacement, but those are still in only experimental stages. They are not even gone a registry or a human trial.
Okay, thank you very much, Dr. Khanna.
Thank you.